Bismillah ar-Rahman ar-Rahim. Today I'm going to talk about cardiac afterload. I think this is a very important topic when you are dealing with the heart. First, the heart, when you look at it, you have to consider that four important points regarding this pump. Number one, the cardiac preload, the afterload, the heart rate and rhythm, and the myocardial contractility. In order to make a comment or assessment of the heart itself, especially when we're talking about left ventricle. So we consider it as what's meant by afterload. Again, is this left ventricle, the preload, contractility, and the rate and rhythm. So these are the four important points to be considered: afterload, preload, contractility, rate and rhythm. Sometimes we add the valve itself to be considered. What's meant by afterload? I think the left ventricle or this pump afterload here is defined as the force against which the heart has to pump to expel blood into the vasculatures, or the stress encountered by the left ventricle against the end diastolic volume. So this stress is done all through the systole. Sometimes they say that afterload, this is the mean arterial pressure in front of it. I think it's better to go through this problem and say, afterload, it is a force exerted by the left ventricle. This is an inotropic effect. How much and how fast the contraction against the left end diastolic volume. This is the stalling law. Increases in the left end diastolic volume. This means more recruitment of the sarcomeres and more powerful contractions. So this is it is a force exerted by the left ventricle against the left end diastolic volume to expel struck volume per minute. This means the cardiac output against what? Against the systemic vascular resistance. So this is a cardiac output against systemic vascular resistance to give you the mean arterial pressure. So this is the afterload is the systemic vascular resistance where cardiac output goes through this pipe system to give you a pressure. We usually look at this, what we measure is the pressure. But the work of the heart is to pump stroke volume per minute is a cardiac output against this systemic vascular resistance, which is the afterload itself, to give you a measurable one, which is the blood pressure. So this is a formula, which is a Laplace law. When you come to the stress or the left ventricular workload, this left ventricular workload equals the cardiac output multiplied by the systemic vascular resistance by the radius left end diastolic volume per unit wall thickness over the wall thickness. So this left ventricular workload is determined by the stroke volume itself, heart rate, systemic vascular resistance, and left end diastolic volume, in addition to the wall thickness. I think this workload will increase with the increase in the stroke volume, the heart rate, systemic vascular resistance, and the radius, and decrease with the increase in the wall thickness. This should be considered because we are going to discuss this workload. You know that the heart is working at rest, and at the same time it has a reserve capacity to work with an exercise or according to the metabolic demand, so the workload can be increased. And this workload, which can be increased, sometimes becomes limited, as in case of heart failure. So it becomes low and fixed. So in this case, increase in stroke in the systemic vascular resistance may be associated with decrease in the stroke volume. We're going to discuss it when we talk about the heart failure. So what about the systemic vascular resistance? Systemic vascular resistance, so this is the left ventricle contracts against left end-systolic volume to eject stroke volume, which is cardiac output per minute, against systemic vascular resistance to reduce pressure. Systemic vascular resistance equals, or this afterload is systemic vascular resistance, the elastic property of the word itself is against the flow, at the same time the reflected wave from the arterioles and the viscosity of the blood. All these has a share in in afterload against left ventricular work. As I've mentioned before, that the heart has a reserve capacity. It has a reserve capacity at rest. There is workload, and with exercise, there's an increase in the workload, or according to the metabolic demand, this will increase. So this will increase in the form of this reserve capacity, Frank-Starling mechanism. This is a radius. Increase in the left end-stroke volume will be associated with increase in the force of contraction. Myocardial hypertrophy as an increase in the wall thickness against the increase in systemic vascular resistance. And the last one, which is increase in contractility and the rate. That's why this is this is a normal. There is a cardiac reserve. This is more with coronary disease, or in the case of valvular disease, sometimes or heart failure. This is encroachment of the cardiac reserve capacity, and so this is will manifest itself in the form of heart failure with different degrees. What about the systolic pressure volume loop? In order to study the problem of the afterload, I think it's better to study this curve or this loop. This is the pressure volume. This is the pressure, and this is the volume axis, and this is afterload. I think this is same vascular resistance. At the same time, this is the diastolic pressure volume curve, and this is the systolic pressure volume curve. Or sometimes I think it's better to say this is the curve for the pressure, mean arterial pressure, and this is the axis for the systemic vascular resistance, and this is the axis for the volume. This is the wave for the heart itself. Say starts by the contraction with closure of the mitral valve, and then the heart starts isometric phase of contraction, which it says about 0.05 seconds, till it reaches the pressure is augmented till it becomes equal to the diastolic, and then exceeds the diastolic to open the aortic valve, and so there is ejection of the blood with decrease in the size of the left ventricle. So there is a decrease in the force, and the force decreases gradually till the pressure returns back to the aortic pressure and the systolic pressure, and the contraction is ended. And this usually takes about 0.25 seconds. And here, in this case, the aortic valve closes and it starts at the relaxation, which is as a isovolumic phase of relaxations, where the pressure decreases gradually with the same volume, no change in the volume, because the aortic valve is closed and the mitral valve is still closed, till the pressure comes below the mitral valve. So the mitral valve opens, and this is the isometric phase of relaxations, which is about 0.15 seconds. Then starts the rapid flow and the flow, and after that the atrial kick to give us the diastolic time, and then starts systole again by the closure of the mitral valve and starts the isometric phase of contractions. This diastolic area is about 0.5 5 seconds. When you come to the diastolic time, asymptotic phase of relaxations with this diastolic time, all of it at about 0.5, 0.7 seconds. And this is the systolic time, which is asymptotic phase of contractions and the ejection phase, about 0.3 seconds. 0.3 seconds plus 0.7 seconds, 1 second. So this is the rate here and is about 60 beats per minute. Here, I think this is the pressure. If you say this is the mean arterial pressure, at this mean arterial pressure, this is the systemic vascular resistance, and this is the stroke volume multiplied by the rate to give you the cardiac output. So this is the cardiac output multiplied by this systemic vascular resistance will give you this mean arterial pressure. So this is a pressure. At that point, this is a curve for this for such a pressure. I think this is the relation which can make our comments later on this relationship. What about systolic time and afterload? As I mentioned before, the systolic time is about 0.3 seconds, and the diastolic is about 0.7 seconds with a rate of 60 beats per minute. So this is in the case of tachycardia, there's encroachment on the diastolic, but sometimes the systolic time decreases, what we call muscle fiber shortening velocity. This is in the case of the afterload. This is a normal one. If in the case of the afterload, this is the velocity of contractions. With this negative entropy, where the curve is shifted to the left, so the afterload with the same afterload, the velocity decreases. It is clear here from this part that increase in the afterload will be associated with decrease in shortening velocity, which means that there's increase in the systolic time. But on the contrary, increase in the preload or increase in inotropy will be associated with increase in the shortening velocity. Increase in the shortening velocity means decrease in the systolic time. And the increase in the systolic time is important. This means that it is a good function of systole. Systolic dysfunction means, number one, increase in the systolic time, increase in the left end systolic volume, and decrease in stroke volume. So, increase in the systolic time, this is a systolic dysfunction. And this increase will be on the expenses of the diastolic time, which means that the maximum allowable rate for the performance of the left ventricle will be less than expected or will be less than normal. This means that if you exceed this rate, this means that the venous return will not be taken fully, and the retention of venous blood behind right and left ventricle will occur with increase in the central venous pressure and increase in the pulmonary wedge pressure. Afterload and stroke volume. When you look at increase, this is afterload, this systemic vascular resistance. At this systemic vascular resistance, in this case, this is a white one, this is a normal. This is the stroke volume with the systemic vascular resistance to give us this is mean arterial pressure. In cases of increase in the systemic vascular resistance, it's the red one. This decrease in the stroke volume because here there's no matching, what we call mismatching. We're going to discuss it later. So increase in the afterload or increase in systemic vascular resistance will be associated with a decrease in the stroke volume. On the contrary, decrease in the systemic vascular resistance will be associated with an increase in the stroke volume. So there is a reversed relationship between the afterload or systemic vascular resistance and the stroke volume or the cardiac output. But this is a very important problem you take care. This is a mean arterial pressure. If the mean arterial pressure is the same, increased systemic vascular resistance will be assured with decreased cardiac output Decrease in the systemic vascular resistance will be associated with the increase in the cardiac output. This means that if the mean arterial pressure is fixed, no change in the mean arterial pressure, increase in systemic vascular resistance will be associated with decrease in the cardiac output. Decrease in the systemic vascular resistance will be associated with increase in the cardiac output, so long as the mean arterial pressure is the same. And this usually is done in cases of heart failure. Heart failure, if this increase in the systemic vascular resistance, this will be associated with more failure. If you give some sort of vasodilators, like ACE inhibitors and ARBs, this will decrease the afterload or decrease the systemic vascular resistance with concomitant increase in stroke volume and the cardiac output without changing the arterial pressure. We'll discuss later with heart failure. This is clear from this curve. When you look at this is end diastolic volume, and this is the end systolic volume. This is end systolic volume, and this is the stroke volume. When you give something like ACE inhibitors or ARBs to this patient, there is a decrease in the there is decrease in systemic vascular resistance with concomitant increase in the stroke volume, and at the same time there is a decrease in the end systolic volume. And this is more improvement. There's more increase in the stroke volume with more decrease in the end systolic volume, and this is more increase in the uh, stroke volume with more decrease in the end systolic volume. This is usually what happens when you give a patient when the patient with heart failure and you want to decrease afterload, so give ACE inhibitors ARBs. The target of this is to decrease the systemic vascular resistance and to increase the stroke volume and to increase cardiac output. And at the same time, there's improvement in the systolic functions with decrease of end systolic volume. And at the same time, the blood pressure, no change in the blood pressure, or minimal change. That's why you increase the dose of the ACE inhibitors or ARBs so long as the blood pressure or mean arterial pressure did not change. This means that systemic vascular resistance is decreasing with concomitant increase in the cardiac output. Afterload matching and mismatching. As I've mentioned before, this is the systemic vascular resistance. This is the stroke volume. And what will happen if you increase the afterload? When you increase the systemic vascular resistance, for sure there's an increase in systemic vascular resistance. This one of two things. Either there's a diastolic increase in the diastolic volume and left end diastolic volume. There's no, or there's increase in the left end diastolic volume. What we call matching, increase in the afterload, usually is associated with concomitant increase in the left end diastolic volume. And this left end diastolic volume leads to increase in the stroke volume or restoration of the stroke volume to be the same. With the increase in the afterload systemic vascular resistance, this increase in the blood pressure. So the blood pressure will increase. So what will happen when you look at the patient during physical exercise? Physical exercise, this is the metabolic demand will increase and the venous return will increase. At the same time, there is some sort of increase in systemic vascular resistance. Increase in systemic vascular resistance will be associated with increase in left end systolic volume, and at the same time, there is a decrease in the stroke volume. But the compliance of the left ventricle is good, so and the venous it will accommodate more venous return. So the end systolic volume is increased, and so this is the other one. So the stroke volume increased, and this leads to increase in the cardiac output. In face of increase on the systemic vascular resistance, the blood pressure will go up. So this is what we call is matching. Increase in the afterload or increase in the systemic vascular resistance will be associated with increase in the left end diastolic volume. This is what happens. Again, so this is a patient, this is white. Increase in the afterload is associated with concomitant increase in the left end diastolic volume. So cardiac stroke volume increased or the cardiac output will be increased in addition to the increase in the systemic vascular resistance, so the blood pressure will increase. So we are shifting the curve to the left. In addition to this, sometimes the exercise, catecholamine itself has a positive inotropic effect, means positive inotropic effect that the stroke volume will increase with decrease in the left end systolic volume. So the stroke volume is increased with increase in the left end diastolic volume with decrease in the left end systolic volume. So the stroke volume is increased to match in addition to the increase in systemic vascular resistance, so the blood pressure will go up. This is what we call afterload matching. But sometimes we face a problem of afterload mismatching, as in cases of diseased heart, ischemic heart, or sometimes a patient with late hypertension or hypertension for a long time with decreased compliance of the left ventricle. And this is a very important point. Increase in systemic vascular resistance will be associated with the concomitant decrease in the stroke volume. So the blood pressure is the same. When you look at the patient early in hypertension, there is increase in the systemic vascular resistance with concomitant increase in the stroke volume. So the stroke volume is the same, but the systemic vascular resistance is increased, so the mean arterial pressure or the blood pressure goes up. By time, this diastolic dysfunction and this increase in the systemic vascular resistance or afterload is not associated with concomitant increase in left end diastolic volume or the stroke volume, but the stroke volume decreases, so the blood pressure is high with the increase in the systemic vascular resistance, but with decrease, even decrease in the cardiac output. And this is the later case of hypertensive patients with left ventricular hypertrophy or stiffness of the left ventricle. So this is what we call mismatching. And this happens if there is some sort of accelerated hypertension, increase in the systemic vascular resistance high. This is will be associated with concomitant decrease in the cardiac output, which might lead to pulmonary edema. So this is a increase in the systemic vascular resistance. In this will be associated with decrease in the cardiac output and increase in the mean arterial pressure also. This is maybe another important point. So the patient may come to with severe hypertension with heart failure. This is due to increase in the systemic vascular resistance without concomitant increase in the stroke volume or the cardiac output, or on the reverse, there is a decrease in the stroke volume and the cardiac output, and accordingly this will be associated with increase in the left end diastolic pressure without increase in the left end diastolic volume, and pulmonary pressures will increase and pulmonary edema might happen. So this is also again, this is mismatching as I've mentioned before. This is increase in the stock in the systemic vascular resistance without concomitant increase in the stroke volume or the left end diastolic volume due to the stiffness of the nerve. So the blood pressure will go up, and this is a very important point. This is in case of hypertensive patients. Hypertension, this is no increase in the cardiac output, but the systemic vascular resistance is high, and this leads to hypertension. So there's no, when the patient makes an effort, this is an effort might lead to more increase in systemic vascular resistance, but at the same time, there's no concomitant increase in the cardiac output, and so the work of the patient or the effort of the patient will be limited. Hypertension again, this is the hypertension, this is the curve, our curve. When you look at this is a patient early in hypertension. Hypertension, it is the cardiac output multiplied by the systemic vascular resistance. There's increase in the systemic vascular resistance, and it was concomitant with matching, with afterload matching with concomitant increase in stroke volume, so the blood pressure goes up. That's why if you want to come down with the blood pressure, simply you give something to decrease, to come back with the systemic vascular resistance, like ACE inhibitors or ARBs. This will come back, or calcium channel blockers. Sometimes beta blocker itself, again, is sympathetic. So the systemic vascular resistance will come back, retain back, will decrease, And this decrease will be associated with decrease in the, for sure, returns to the back to the normal, decrease in the stroke volume, and the blood pressures will come down. This is the second part. If late in the hypertension, as I mentioned before, the heart become hypertrophied and the compliance of the heart is bad, so the stroke volume decreased with increases in the systemic vascular resistance and keeping the blood pressures high. So in this case, we are a little bit more in bad situations where the systemic vascular resistance is the main factor for the hypertension, but the perfusions or the cardiac output is not good. That's why when you look at this curve, this stroke volume, and this is after systemic vascular resistance. In the normal persons, or normal blood pressure, this is the afterload. Increase in the afterload is not associated with, will not be associated with decrease in the stroke volume due to the afterload matching. And also in the hypertension, but with the increase in the hypertension for sure, this will be associated, increase in the afterload systemic vascular resistance will be associated with decrease in the stroke volume, but not the same like a patient with heart failure, moderate heart failure, severe heart failure. So this is where, and this is the afterload itself will be associated, increase in the afterload systemic vascular resistance will be associated with decrease, severe decrease. This is the systemic vascular resistance. This is the stroke volume. Increase in the systemic vascular resistance will be associated with decrease in the stroke volume. The heart failure, this is the systemic vascular resistance and this is stroke volume. Increase in the systemic vascular resistance will be associated with severe decrease in the stroke volume. So this is the relation between the afterload or systemic vascular resistance and the stroke volume or the cardiac output. So that's why the patients in the normal hypertensive patients, there's no problem. But later in life, the patients and all the patients with long stay hypertension, this would for sure will be associated with decrease in stroke volume due to the stiffness or starting mismatching of the heart. In this patient with heart failure, for sure there is no matching. It is already mismatching, and therefore increase in the afterload will be associated with decreased stroke volume. Or increasing the blood pressure will be associated with more decrease in the stroke volume. That's why a patient should control the blood pressure for a patient with heart failure, or at least give ACE inhibitors and ARBs in order to come back or to come down with the systemic vascular resistance in order to secure the delivery of good stroke volume and cardiac output. That's why, according to the guidelines, you have to start. This is in case of emergency. You have an patient emergency with severe hypertension in order to avoid. You have to give sodium nitroprusside or nitroglycerin or nicardipine. This is to decrease the afterload, or phenoldiazepam or hydralazine and nalabrate. Also, this is to decrease the afterload in order to increase the cardiac output or stroke volume and cardiac output. This is also the same thing. So this is the most important point when you look at this. This is you are dealing with the afterload. Decreasing the afterload is an important issue to increase the stroke volume and to increase cardiac output, and at the same time to decrease the blood pressure. What about heart failure? Heart failure, this is the shaft of this curve from to the right. Shaft to the right, this means that at the same systemic vascular resistance, this is the systemic vascular resistance in the white one. This is stroke volume. At the same vascular resistance, systemic vascular resistance, the stroke volume decrease because we do not have matching. We have mismatching. This is a bad left ventricle which does not accommodate the venous return. This is a stiff left ventricle. So when you look at this, this is a problem of decreased contractility. Decrease in contractility will be associated with decreased stroke volume at the same systemic vascular resistance. And accordingly, systemic vascular resistance with decreased cardiac output will be associated with decrease in the blood pressure. What to do in the treatment? For sure, you can give something like positive inotropic to shift the curve from the right to the left. This is again back to the left. So this is with the same systemic vascular resistance, the stroke volume will increase, and the cardiac output will increase, and the blood pressure will improve. So this is one line of the treatment of heart failure is to give positive inotropic. Or to do another thing, which is very important point, and you give something like this is the same blood pressure, and this is you come down with the systemic vascular resistance from this is the yellow one to the white one. Decrease in systemic vascular resistance will be associated with increase in the stroke volume, and in this case, you look, this is the same blood pressure. This is what usually we do with the patients with heart failure. We usually give ACE inhibitors or NIBs in a slower and a lower dose, and then build up the dose over days. And this is lower doses will lead to decrease in the systemic vascular resistance with concomitant increase in stroke volume, so the blood pressure will not change. Increase the dose again without changing the blood pressure. This means that there is a decrease in the stem vascular resistance with concomitant increase in the stroke volume, concomitant increase in the cardiac output. This is our target. So, and when you reach to a certain dose, when the blood pressure starts to come down, this means that the heart is no more increase in the stroke volume or the cardiac output, so we have to go to the previous dose. So this is the philosophy of giving a patient with heart failure the ACE inhibitor or ARBs go down with the systemic vascular resistance to increase the stroke volume, to increase the cardiac output to the best or to the maximum. Again, this is that said, when you patient with heart failure, when you go with the heart failure, it is very nice to go with the when you go with the systemic vascular resistance from this line to this line. This will be associated with increase in the stroke volume and also cardiac output. When you go from the out, this is the systemic vascular resistance from this to that. This is look at this red one. So you will get a marvelous improvement in the stroke volume when you decrease the systemic vascular resistance. That's why this is the recommendations from the guidelines, whether this is reduced ejection fractions ACE inhibitors or ARBs, or in preserved one, you have to give systolic and diastolic blood pressures should be controlled in order to prevent morbidity. And also the preserved one, these ARBs might be considered to decrease the hospitalization of the patient. In the case of acute heart failure, you have to use infusion, IV infusion of nitrates or sodium nitroprusside in order to decrease the afterload. Cardiogenic shock, the same thing for cardiogenic shock. This is a form of heart failure where there is decreased cardiac output or marvelous increase in the systemic vascular resistance. The same philosophy, and this is the cardiogenic shock. This is the cardiogenic shock. This is the other one. Mean pressure is low, and this also, this is the patient with the systemic vascular resistance. This is one, and this is the stroke volume is decreased, and with the increase in catecholamines, also this increase in systemic vascular resistance and this cardiogenic shock, and with more decrease in the stroke volume, and this is a very bad state for such patient. What to do is to give if you give something to decrease the systemic vascular resistance, this means that you are increasing the stroke volume. So this is a very important point. Or that's why most of the drugs used as a vasodilator will decrease the systemic vascular resistance, like nitrovasodilators, nitridatide, or sometimes isoproterenol. This is will be associated with decrease in systemic vascular resistance and increase in cardiac output. So the philosophy, but you are going to when you give something like vasodilator, you have to take care from the venous return. It is another issue, but we are talking about this point. Decrease in afterload or decrease in systemic vascular resistance will be associated with increase in stroke volume, but relatively. That's why. Uh, but another important point in the cardiogenic shock or severe heart failure is that you have to give the patients mechanical support him with mechanical ventilations. Why mechanical ventilations? I think the problem of the ventilatory support to the patients with heart failure depends on a very important part, what we call high negative oscillations of intrinsic pressure. And this is when patients with left ventricular failure or pulmonary edema or congenital pulmonary edema, there is interstitial edema and alveolar edema. And this alveolar edema and interstitial edema will interfere with the oxygen with the oxygen passage of oxygen, what we call increase in the alveolar arterial gradient, and this will lead to some sort of hypoxia. But this is number one. Number two, stiff lung itself will be with decreased compliance of the lung will add something important. The patient will be tachypneic, and this tachypnea will exceed the limit of the rate, and this will lead to what's called dynamic hyperinflation. So, and dynamic hyperinflation, this means that there is increase in the functional residual capacity and decrease decrease in the tidal volume. Decreasing the tidal volume with fixed dead space, this means that there is decrease in the minute alveolar volume. Decrease in the minute alveolar volume, this means that there is increase in carbon dioxide. So the patient will suffer hypercarbia. So the carbon dioxide will increase. This also adds to the decrease in the oxygen. So the oxygen there will be hypoxia due to the increase in alveolar gradient and hypoxia due to hypoventilation. This is number one. Number two, the third important thing is this is stiff lung will make the patients make a very big effort to inflate the lung. So instead of making a negative blood pressures about -3 or -5 or -10 centimeter water, in this case he has to do an effort which might go up to -30 centimeter water or more in order to inflate the lung, in order to deliver the tidal volume. That's why this is a negative thoracic negative thoracic oscillation. This negative interthoracic pressure, which is the pleural pressure, negative pleural pressure, the heart itself is present in the pleural space. This is what we call the cardiac fossa. So this negative pressure will be reflected on the left ventricle and will will be reflected on the left ventricle itself and the capillary. We'll see. That's why this negative intrathoracic pressure is very important as to increase the afterload. So this is the definition of the heart failure, or the pulmonary wedge pressure will be increased. What is the problem here? This is a normal. When you have this is the normal, you do some negative intrathoracic pressures in order. This is to take your respirations about -5. But in case of cardiogenic pulmonary edema, this will be very large. It will be very hard. So this is the left ventricle, which is contracting against systemic vascular resistance. And here this is the negative pressure, pleural pressure, pulling it here. So this is the transmural relations would be the mean arterial pressure minus this pressure. Minus this pressure, this is in minus here, instead of -5 or -5 centimeter water or -1 millimeter mercury, this will be added to this to the mean arterial pressure. If this negative interstitial pressure is high, this means that you are adding to the workload of the left ventricle. This will be added to the mean arterial pressure. So the left ventricle is working in the directions, and you are pulling it. So what will happen if you put the patients on the mechanical ventilations? Mechanical ventilation, this means this is a post pressure ventilation, so you are pushing and instead of pulling, and therefore the afterload will decrease, and this means that decrease in the afterload or decrease in cerebrovascular resistance will be associated with increase in the cardiac output, and this will give you chance to correct yourself, and this is a bridge till you treat the patient, so that to give him something vasodilators or positive inotropics or whatever. So this is a bridge, but this bridge gives you chance in order to avoid hypoxia, hypercapnia, and cardiac arrest for the patient. So this is a vicious circle. This is increase in lung edema, decrease in the compliance, increase in the interthoracic pressures, increase in the afterload, increase more pulmonary edema, and more lung edema, increase in the pulmonary pressure, more lung edema, and so the vicious circles. When you put the patient on mechanical ventilation, this negative interthoracic pressures become positive, and so the afterload decrease, the pulmonary pressure will decrease, the edema will decrease, and the compliance of the lung will improve. And this is the workload. This is the systolic pressure, so the mean arterial pressure minus intrathoracic pressure. This is the pressure multiplied by this is the diameter over 2 by the wall thickness. So this is the philosophy of putting the patient on the on the ventilator to decrease afterload, to improve oxygenation, and at the same time to unload the the pump, the respiratory pump, and this will help the patient as a bridge tell you correct the etiology of pulmonary edema or heart failure. Another important point, this is this is alveoli and this is the capillary, and here the problem of the transudation here, this is the transudation pulmonary pressure increase becomes more than the oncotic pressure, so this pulmonary edema. So this is the transcapillary pressure. When you put the patients on mechanical ventilation, the pressure here will will uh, 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 will decrease the hydrostatic pressure. Normally, normally, when you look at this is a hydrostatic pressure in the pulmonary edema is very larger, more than the oncotic pressure. So this sends transduction to the interstitial and to the alveolar pressure, to the alveoli. This is and when with the presence of high negative interstitial oscillation, interstitial pressure oscillations. This is the patient is taking is making a high negative lower pressures will be reflected in the alveolar pressures, and this means that the hydrostatic pressure is augmented as transudation is augmented. But when you put the patient on positive pressure ventilations, this is the hydrostatic pressures and the alveolar pressures became positive instead of negative. So this is well antagonize the effect of hydrostatic pressure. So there is a concomitant decrease of the hydrostatic pressures, and therefore the edema will decrease till you correct the etiology. Concerning an important point when you put the patient on mechanical ventilations, with heart failure, as I have mentioned before, this is the heart failure, this is the decrease in the cardiac output, and an increase in the pulmonary pressure and increase in the edema. First thing to do is to give either to give postphenotropic to shift the curve to the left in order to increase the stroke volume and then the cardiac output, or at the same time, as I've mentioned before, to decrease the systemic vascular resistance by ACE inhibitor ARBs in order to improve the cardiac output, and or to put the patients on mechanical ventilations in order to unload the left ventricle. This is the mechanism by which the during pulmonary edema, this is the pleural pressure, which is having its negative effect on the left ventricle and increasing the afterload. That's why this is increasing the afterload. When you put the patients on mechanical, this is a normal person, this is a patient with pulmonary edema, the pleural pressure is increased too much, and this is reflected on the cardiac fossa. When you put the patient on ventilator, weaning of the patient is very important. And when you put the patient with positive pressure ventilation, pressure support ventilation, like that, this is mean that the pleural pressure is high, and this is makes some sort of unloading to the left ventricle, and this is very important. But weaning the patients, this is a patient with pressure support ventilation. You are unloading the left ventricle. When you decrease the pressure support ventilation from 20 to 10, this means that the unloading will decrease. When you put the patients on CPAP, CPAP, there is no driving pressure by the machine. The only driving pressure is that of the patient. This is a negative pressure. So now here you are unloading, here you are reloading the patients. So that's why when you start weaning the patient, this is a very important point. With the heart failure, you decrease the pressure support gradually and keeping an eye on the pulse rate and the blood pressure. If there is no change in the pulse rate and blood pressure, this means that the reserve capacity of the left ventricle is doing well. And here you decrease much the same pulse rate and then the blood pressure. This means the reserve capacity. Here you remove the unloading, and now you are reloading the left ventricles. And look again, when you put the patients on CPAP, this is the pressure support, this is the pulse rate and the blood pressure. No change in the pulse rate and the blood pressure, so you can wean the patient of ventilation. Sometimes this is the last point. Sometimes with this patient, when you extubate the patient have some sort of stridor. Stridor is the same mechanism. This stridor will be associated, will increase in the pleural pressure, and this will be reflected on the cardiac fossa. This will increase the afterload of the patient, and the patient might develop again heart failure or pulmonary edema. And in this case, the only solution for these patients is to put intubations. And when you put the tube, this means that the start is no more stridor and no more increase interstitial negative pressures, no more increase in the afterload, and the afterload returns back to normal. And this is the last point. So this is the afterload with a critical care person. Thank you.